Greetings from eMedi News, Heart Care Foundation of India and Board of Medical Education, Mulchand Medcity. Welcome to our show, Chat with Dr. KK. We have with us Dr. Rohit Aggarwal, who is Assistant Professor of Medicine Rheumatology and Medical Director, Arthritis and Autoimmunity Center at US-based University of Pittsburgh. Welcome to our show.
Thank you.
What we are going to discuss today is the subject of sarcoidosis. I recall when I was in my medical college, there were only 1 or 2 lectures we had on sarcoidosis. Invariably, our professor taught us that sarcoid is a diagnosis by exclusion, always look for tuberculosis, and they said was 90% of sarcoid will ultimately turn out to be tuberculosis. That was our undergraduate teaching. With that perception, we started our practice. And in our practice, we started missing a lot of cases of sarcoid, and in the last 10 years, my God, we see that sarcoid is rampant in the society. I mean, as a specialist, I can say rampant. As a family physician, probably you will say that it's common or it's not uncommon in the society. So let's talk about the subject of sarcoid, how to diagnose, what is the role of a family physician, what is the role of a physician, and how to treat sarcoid. So when I say that sarcoid means TB, that used to be our perception. That sarcoid is burnt out TB. Some people said that you cannot differentiate sarcoid. So first of all, what is the prevalence of sarcoid in the society across the world?
Across the world, I would say it's about, if you see all of the, if you 100% percentage wise, about 0.5% overall population. It's more in African American, so about 1 to 2% in African American, but overall half to 1% in general population.
Half to 1%
So
is a huge number. It's pretty high. Yes. I mean, 1% is a tuberculosis. You have cancers 1%. So as big as cancer.
No, rheumatoid arthritis is 1%.
It's a big number.
It's a big number.
So sarcoid is a big number. That means every 100 patients, a GP on an average here sees 100 patients a day.
Right.
And if he sees 100 new patients, one of them will be sarcoid.
Yeah, possible.
Okay. And what way sarcoid can present? We say it's a protein manifestation.
So, if you talk about most common presentation is pulmonary, and what generally would happen is patient would have systemic features like fever or not feeling well, fatigue, and they would have lymphadenopathy. That sometimes get undetected and it gets better over the period of time, whether you treat it or don't treat it. So that's probably the most common presentation of sarcoidosis. The second most common is that it doesn't get better. So the same presentation doesn't get better, it actually progresses to involve parenchymal, reticular nodular involvement of the lungs. And that's probably the second most common presentation of sarcoidosis, where the patients start developing shortness of breath, cough, dry cough and shortness of breath with fatigue.
So in a country like ours where we say TB, how do I pick up with the clues that it may not be TB, it may be a sarcoid?
If you have additional features, for example, if you have other organ involvement, if the patient comes to you with shortness of breath and cough and has both ankles swollen up, that's
so arthritis.
Arthritis.
So one is the arthritis. You
rash,
can have a sarcoid.
Rash is also another feature.
Rash is uncommon in India because in all, whether we have rheumatic fever, everywhere we don't see that rash.
Happens. Erythema nodosum
very
don't detect it. And the third thing is eye involvement. And the fourth probably is lymphadenopathy, generalized lymphadenopathy, but that will be different.
So in every patient where you suspect sarcoid, send them for an eye examination.
That's definite.
Okay. In eye, what do
because in eye the problem is the patient may not have any symptom because they may have posterior eye involvement, which may be silent and may not present with any feature. So ophthalmological examination is very important.
How common is kidney involvement?
Kidney involvement is very rare.
It's very rare.
Very rare.
So if a patient has lymphadenopathy and with an involvement of a joint, so joint and lymphadenopathy, with or without eye involvement, look for sarcoid.
Yes. I can even tell you if a patient calls me, if a young patient calls me and tells me that I have both ankle hurting and my first test of choice is CT scan of the lung. And they don't want to do it because they said, I don't have any problem with the lung. Why are you getting a CT scan? Because you will find lymphadenopathy. The positive predictive value is very high.
Okay.
Bilateral ankle
in a patient with sarcoid, the involvement of an ankle will be inflammatory or non-inflammatory?
Inflammatory. Bilateral.
It will be inflammatory. And it will be in the inflammatory polyarthritis.
Yes.
In the differential diagnosis of rheumatoid, but it will be seronegative.
Yes. And
will it be damaging?
The joint? It's generally not damaging.
Generally not damaging.
But acute
and
inflammation.
What about anti-CCP?
Negative.
Negative, rheumatoid negative,
Rheumatoid
ESR and
probably
CRP.
10-15% cases will be positive.
ESR and CRP
ESR and CRP will be slightly high.
slightly on the higher side. Okay, in the lungs, when I see the chest X-ray, what is typical of sarcoid?
So typical is hilar lymphadenopathy.
Which
right,
one? I mean, versus tubercular lymphadenopathy.
right paratracheal is very common. Then you may find also streaks of reticulonodular opacities around the bronchovascular bundles. If you can pick it up on the CT
So
scan.
whenever I get a lymphadenopathy, mediastinal lymphadenopathy on an X-ray, I order for an
CT scan,
Which
that's
CT?
must.
HRCT or CCT?
You need a CECT, contrast enhanced, because you're not looking for parenchymal involvement, you're looking for lymph node and reticulonodular.
So I order for a CECT.
Yeah.
Is there any role of any other test like MRI of the chest? No. Simple
no.
CECT.
Yeah.
When I go for a contrast CECT, it may give me a suspicion of sarcoid.
Yes.
Okay. Now, suppose I'm suspecting sarcoid. I've seen by the CT or by the arthritis or by the eye involvement. What next? What further test?
So the further
Is there any role of ACE levels?
So there is a role of ACE level. So the role of ACE level is such that if you have a positive ACE level at a higher titer, there are not many things give you very high ACE level. So if somebody has a, if let's say normal range is 60, and you have an ACE level of more than 100, that's significant, and that suggests sarcoidosis with a very high positive predictive value. But let's say if you have an ACE level of 60, 70, that's non-specific.
So if the ACE level is 100, suppose,
Or more, yeah.
suppose a person comes to you and says that my X-ray was abnormal, my ACE level was 100, I did not take any treatment, now my ACE level has become 60, does it mean sarcoid has gone into remission?
No, that's not true at all. In fact, normal ACE level is very, you cannot reject sarcoidosis if you have a normal ACE level.
No.
You can suspect.
What I'm trying to say, if a patient is sarcoid, he's gone into remission, will the ACE levels go down?
Yes, ACE level goes down.
That means he has gone into
But
remission.
when they flare up, that not necessarily mean the ACE level will go up again.
Okay. Now, if a patient comes to you with sarcoid, how do I treat?
So the treatment, first of all, is I just want to touch base on the diagnosis. The diagnosis of sarcoid is not confirmed unless until you have done a biopsy.
Okay.
At least 1 or 2 tissue you have to show granulomas which are non-tubercular and non-malignant. So you have to show that. Now there are exceptions to that case. As I said, Lofgren Syndrome, which is a triad of bilateral hilar lymphadenopathy, ankle arthritis, and erythema nodosum. For that you don't need biopsy. That's a classic syndrome. In fact, I would say a young patient comes with bilateral ankle arthritis and hilar lymphadenopathy. Probably you can, and if you have higher ACE level, you can exclude. You don't want to do biopsy.
Okay. Which biopsy we do?
You would try and do transbronchial mostly.
Most of them in India won't
Go
not
for
be that easy.
Won't be that easy. So without that, it will be very hard to differentiate it from TB or even lymphoma. Unless until you have other features, let's say you have rash, arthritis, or eye involvement of sarcoidosis.
So normally here, if you have a bilateral lymphadenopathy, ACE levels are 110, I think most of the people will start treatment.
It's probably true, but you may may get one case in 100 cases that you treat that it turns out to be something else, and then
So you say transbronchial biopsy should be done.
Should be done unless until you have other solid evidence of sarcoidosis. As I said, Lofgren is one. Eye involvement is another case where you can be comfortable in that it could not be TB because you have enough clinical features for it.
Okay, how do we treat?
So the treatment is generally what you start with about 40 to 60 milligrams of prednisone. Depends on the severity. So if you do not have much parenchymal involvement, I would say 40 milligram is enough. If you have a severe parenchymal involvement to begin with, I would go with 60.
How long?
So 40 milligram for a month, and you taper it every month by, so let's say if you start 40 for a month, you will cut down to 30 next month. Then another month you will cut down to 20. If you will cut down only if patient is keep getting better. If the patient start getting worse, you would not cut down, you will hold on.
And you give it for 6 months and then what?
So, but you give it for 6 months, bring it to about 5 milligrams, and then you continue for another 3 to 6 months until you're completely sure that is not coming back and you've resolved the problem. So I would say any significant sarcoid case, you have to treat for about 6 to 12 months. And common problem that I see is physicians tend to cut short the treatment because patient is feeling better. And
okay. If I do it for 1 year and then the disease has gone into remission, then it may remain in remission for how long?
It may remain for remission forever, or it may only for few months.
Okay. What about steroid sparing drugs?
So steroid sparing drug role comes in a patient with single organ involvement like lung. If they have failed the first good course of steroid. that's the indication of steroid sparing drug like methotrexate or azathioprine. When you have done everything.
So we have to give a trial of steroid.
Yes, if for a single organ. So let's say now you have neurosarcoid, I would start steroid sparing drug right away, because I know that it is not going to get better only with steroid. The data has shown that only steroid is not good for severe sarcoidosis.
What so patient comes to us at a stage when he already has interstitial lung disease?
Then you have to do additional steroid sparing drug. Only steroid is for initial treatment when you have no damage, you have just lymphadenopathy, some infiltrates in the lung,
so
nothing
if
bad.
you have a multiple organ or if you have interstitial lung fibrosis,
severe,
then you treat it like rheumatoid.
Exactly.
I mean, when I say methotrexate,
yes.
regime of a rheumatoid regime,
yes.
Same
yes.
regime you can continue.
Same regime, less aggressive a little bit, because sarcoid also give little bit of bone marrow suppression. So generally we don't take methotrexate to 25, about 20 milligram is where we settle down.
Normally here we give 15 to 20.
15 to 20 is right.
If it is more than 20 in any way, it will come back to rheumatologist.
Yeah, for rheumatoid we like to give 25 or something like that.
25 with that. Any other update in sarcoid?
So the sarcoid, the update is the other treatments, if you can't give methotrexate, is leflunomide, Areva, which is available here. Azathioprine is also, so these are 3 oral agents. If you fail this, the newer treatment which are coming up is infliximab, which is available here but very costly. But has somewhat revolutionized the treatment of sarcoidosis. It's an infusion medicine, infliximab or Remicade, that you give every 8 weeks, but it's given only for severe refractory cases.
And how long?
For about, a lot of time, for about a year, and then you start to taper it to see if the steroid has gone into remission. But I'm talking about this drug if for a severe lung, severe neuro, severe eye disease, those kind of things.
So the take home message, what we have taken from Rohit is very clear. If a patient comes to you with an abnormal X-ray, you feel there are lymph nodes, and if the patient also has an ankle arthritis or an eye involvement, always look for sarcoid. And if a patient comes with idiopathic bilateral ankle involvement as an arthritis, always get an X-ray chest done or get a CT scan of the chest done. Look for lymphadenopathy. Don't rule out sarcoid. In our country, where we always talk about TB is fine, but don't miss sarcoid. That's all for today. Let's thank Rohit to be with us in this show. We'll come back with one more show. Till that, goodbye. Thank you.